right. Good afternoon. Hello, how's everybody? Happy July. Happy almost 100 degrees in Texas, right? Good afternoon, I am Dr. Shauna Nesbitt, the Vice President for Institutional Opportunity, and it's my honor to welcome you today to our July celebration of the Americans with Disabilities Act. And we have a fantastic program scheduled today by our own Dr. Kim, the superstar, and she has put together a fantastic panel. So just so you make sure you understand what this is all about, we are celebrating the passing of the Americans with Disabilities Act. Now, the act was initially passed in 1990, but then upgraded in 2008 to include a broader definition of what disabilities really means. So that you understand it better, I pulled a little bit from ChatGPT, that the ADA defines an individual with a disability as a person who has a physical and mental impairment that substantially limits one's major life activities. And that's a very important part of the upgrade in 2008. 2, has a record of such an impairment, or 3, is regarded as having such an impairment. And under the law, learning, reading, thinking, and concentrating are considered major life activities. The 2008 amendment to the ADA requires a broader interpretation of disability by schools, by testing agencies, and employers than the original law. We at UT Southwestern value the importance of every individual and the contribution that you can make to our mission, because everybody has something and every job here is important. So we try to make sure that this environment appreciates all of us and gives us all the opportunity to reach our fullest potential. We have a team of folks who are dedicated to making sure that accommodations are given as appropriate. They are here with us. I want you to wave your hands here, our accommodations team, who are here led by Travis Gill, who's our AVP of Accommodations and Title IX. Thank you for being here and thank you for the work you do. Other leaders who are joining us today, who again, we find this to be a very important part of our mission here and what we do, and appreciating everybody in our environment. Dr. Mark Neve, who is our EVP of Institutional Advancement and interim EVP of Business Affairs. You got to get one more title. As well as Ruben Esquivel, who is our Vice President of Community and Corporate Relations. Thank you for being here. So, as a part of our lunchtime events, we always have food, and it's always good food. Today, we have special guests who have joined us. Mandy and David Robinson are owners of Biddy and Bo's Coffee Frisco and are the proud parents of 8 children, can't imagine it, including daughters Vivi and Lily, who both have Down syndrome. Their daughters have shaped the way they see the world and inspired their commitment to creating opportunities where everyone is seen, valued, and included. Through Biddy and Bo's, they are helping build a community that celebrates ability, fosters belonging, and proves that people are capable of far more than society often expects. They are here and they are providing our dessert, so please thank them. Yes. Yes. Great. Thank you for being here, and thank you for the treats that you're providing. And with that, I will turn it over to our special leader and guest of this fantastic event. I'll tell you that last year when we had this celebration, Dr. Kim reached out to me and expressed her deep desire to really be not just a part of this, but really take on this celebration as a major part of demonstrating how we actually embrace the opportunity to participate in the lives of those with disabilities. And her department and many people across the campus are part of that. So we basically handed it over to her and said, please help us to do this in a way that appreciates all of the contributions. Dr. Kim is professor and chair of physical medicine and rehabilitation and holds the Kimberly Clark Distinguished Chair in Mobility Research at the UT Southwestern. As an internationally recognized leader in pediatric rehabilitation medicine, Dr. Kim is a board certified in the US and South Korea with subspecialty certifications in pediatric rehabilitation medicine and brain injury medicine. She earned her medical degree from Seoul, Korea, completed her residency and neuroscience fellowship training at Yonsei University. She trained additionally in the US, combined in pediatrics and PM&R at DNJ in New Jersey. And her bicultural international experience has shaped her comprehensive and innovative approach to rehabilitation across the lifespan. I could go on and on because there are about 5 pages here about all of her work and all this wonderful thing, but I want to give the time to her and to introduce the panel. Thank you for being here.
Thanks for having me. Yet, 5 pages, after 5 pages, I still feel that I am also have some disabilities because of the language barriers that I always feel. But I really appreciate that you guys all here to share what we PM&R do, but also what we have to do as an organization. So I'd like to talk about the transitioning program as a pediatric physiatrist. So I invited all my colleagues to join us to share our experience, then how we're going to evolve to be the best center for our patients. So today I'm not just talking about the problems, but I like to, at the end of this presentation, I want us to understand better about the care transition and recognize barriers, what we have in the clinics, and then we should reflect on our own assumptions, training gaps and challenges. Moreover, we should be able to identify practical changes that improve access, dignity, and health outcomes. So why transition matters? You know, you don't feel that. I was surprised to see all of you guys here because I thought I may have only my department people will come here because it's a transition program. But transition is really matters. I went and I asked AI, how many people with a disability live in Texas or North Texas area? As you see, it's about close to 1 million out of 9 million has at least a disability. And about 500,000 people has a childhood onset disability. As we define that, disability doesn't mean that only physically disabled, but also cognitively or mentally they also have difficulties. And then about 100,000 in the Dallas and Fort Worth area, they live with a disability. They are grown-ups, but I don't know how many people in our institution see these kind of patients, right? So then the challenge comes, and then because I'm running the transitioning program ever since I started working at Southwestern, and then when I receive the patient, they're 18, 7.5 years old. They already pushed them out to the adult institution, and then they don't know why they get transferred to adult. They are not ready for that at all, and also all the resources is going away. No therapy available, no financially they are not ready for that. Parents are not ready for that, and then as they get old, parents are getting older too. So all the caretakers are having more burden. So during transition, it's not simply handing out the medical record to the other doctors. We don't get it either anyway. We don't get any record. Thanks to Epic, we do get something. I have to review about 30 different charts before my clinic, each new patient. Still, I don't get that much information from the chart. And then what year they're going to kick them out? They start to 17.5 to, if they like them, if they have services, some institutions, particular patient, they keep until 40 years old. So they get very confused too. And then how they prepare this family and patients, they don't. They don't have, I asked our children's health, some particular clinic has a transitioning program, but it doesn't even translate to us at all. They don't have a transitioning program. And also, how do we have a multidisciplinary team clinic here as a pediatric hospital has, right? We don't have those things. So they get very confused during transition. So I put the question mark, adult side, because I was trained for both. So I was like, you know, chameleon. I can be like this, go back and forth. But when I receive them, I don't know, all the incomplete chart. I don't know the story. And then my patient, a lot of patients are mute, actually. And I have to spend a lot of hours to understand them. And I'm not so sure I completely understood them even, right? And then there's no system available to make them comfortable, happy, and then get the right service. So where's the gap occurs? Where the gap occurs? Because we didn't expect them in the past that they're gonna survive longer than what they used to. So now, about 90 to almost 100% adult with or people with childhood onset disabilities such as autism, Down syndrome, cerebral palsy, neuromuscular disorders, they live long. Medicine is not prepared for that at all. So they are tossed to us without any preparation. And then pediatric care used to be well organized and coordinated care. They have a cerebral palsy clinic, Down syndrome clinic, they have a spina bifida clinic. We don't have that clinic. We have a PMNR clinic. Most of people do not know we have a PMNR, physical medicine, we have clinic available. And therefore, when they come to adult, their care just falling into dungeon because providers are not ready. We are not educated. Medical school doesn't teach the disabilities. So nobody or very few people know how to take care of people with childhood onset disabilities. Therefore, the transition has to be well prepared over years. So I was looking for this kind of a system. Who is preparing these things? Since I'm a pediatrician, I went to pediatric articles, and I found that 2005, there's a Maternal and Child Health Bureau. They came up with the gut transfer. They came up with the 6 core principles, which have us prepare their transition from the pediatrics to adults. But implementation is extremely difficult. I never seen it as a pediatrician over 20 years, right? Because of this presentation, I was looking for anything is implemented in pediatric hospital. So we start with around 12 years old. Around 12, they're already preteen or teenager, right? They start to prepare. We start to prepare from the policies, readiness through the assessment, and then transfer the care. So most of perfect care finished by 20 to 23 years old. But we don't do those things at this time. And more so, our patient doesn't have that kind of system. So when they come to the adult world, I think our team is going to talk about it, but you know, do we have an appropriate scale, wheelchair scale? Because we asked them, what's your weight? Oh, I have not been weighing myself for over 10 years. Oh, you don't go to PCP clinic? Yes, we go, but they don't have any scale for us to be measured, right? And then they don't have an adjustable table, exam table. So they barely assess the patient. They just talk to them. But they cannot understand them. So they just threw the medication to them without proper management. So that has been a huge problem. And when I think about my institution here, how are they going to access to the building? Thank God we have valet parking. Is that all? And then when I look at the elevator, it's so small for a stretcher, the people on the stretcher. It's so small for the, what about our examination room? I always fight for the bigger room because my patient, they're all in wheelchair, they come with multiple people, I have to train multiple people, right? And I have to wait for them. So these all the things start, so I said barriers are not only medical, it's beyond than that. So I'm going to share this a little video. So as a pediatrician, I make them walk with any kind of tool. I usually the botulinum toxin. It takes only it took only 4 weeks for me to make her walk. And then we provide continual care. So after the third time injection, she's passing her growth spurt, and then she looked like a normal child. But look at this. I applied PMNR knowledge and skill. Our therapist worked very hard to make them strong. At the same time, our piano colleagues applied the right type of brace. She looks like a normal girl. Then look at this. Then here we go, 18 years old. And he was brought to me. He was in the school. Now he was graduated from high school. And then the orthopedic surgeon sent this guy to me that, Heakyung, make sure that you fix him. He's crouching so much, okay? I said, God bless you. I cannot fix this problem. So then they disappeared, and they came back in 10 months. Only it took 10 months. Look at him, how he's walking now. He barely walks. So from walking to not walking takes only 10 months. Who's going to take this responsibility? This is not a simple problem. This person is going to have all the adult metabolic disease. They get fat, they're going to have blood pressure, diabetes, pressure sore. The caretaker is going to have a back problem. Our PMNR department business is going very well. Our pain doctors, spine doctors is going to do injections, joint problem, they come to our MSK doctors, they're going to do injections, right? Why can we prevent these things? So as my patient gets old, their caretaker gets old too. So this, I got the permission from her mother. The very young looking lady is her mother. She's 40 years old, my patient. First initial evaluation, she said, I said, oh, no. Our team is going to help you transfer. And she said, no worries, I haven't been doing this all by myself. So she was transferring. Mom is 70 years old, even though she looks young. But she's carrying her to transfer her. But thank God we have adjustable bed. So I help only adjustable bed. But my team comes with a Hoyer lift. They help. But I don't think many other department has that kind of a system or instrument to help them out. So now you saw the whole span of their life. And then what happened, this is a simply cerebral palsy case. There's an article came out, and they're summarizing. Our patient has very high rate of stroke, high blood pressure, pain disorders, and they have a significant functional deterioration. You can imagine, as a leader, I always think about the finance component. The impact on healthcare system, the expenses is exponentially growing because from walking to not walking, cause all these problems. So there's transitioning gap. Recently, I received this case, and I had to review her case because she had to, I had to admit her during July 4th. So this 31-year-old lady, very smart, had a master's, and she's on a wheelchair, so in pain, and then nobody was really handling well. So she came to my adult cerebral palsy clinic. And then at that time, I realized that why she used to walk with a walker or with crutches, but she cannot walk anymore because of pain problem. Her pain, nobody really is studying where the pain coming from because she's a cerebral palsy. So they don't do any studies. So I went back to all EPIC chart. The first chart in EPIC was 15 years old. About 16 years ago, chart I started to read. She started already complaining this knee pain when she was 14 years old. And then the orthopedic surgeon said, oh, okay, you can have a brace. No X-ray, no MRI, nothing else but gave the brace. Now she's 18. You gotta leave my institution. She left. And she came to us, and we are doing muscle stiffness. We call it spasticity management with botulinum toxin. Meanwhile, she moved to Houston to study. She was there 9 years, and she's complaining about the severe knee problems. Orthopedic surgeon saw her 3 times, and our rehab doctor saw 3 times. Over 9 years, they did only botulinum toxin. They didn't do any imaging studies, but they recommended heel cord lengthening, who cannot even walk at this time. So nobody is really trying to figure out where the pain coming from. Of course, they gave a vitamin G, gabapentin, to control the pain without knowing the causes. Now, she came back to us to a specialty clinic, and immediately I figured out that she needs orthopedic surgeon's help. So we got the simple x-ray, but at that time we did not have a physician who can handle this a couple of years ago. Now we have an amazing physician now. We have a great partnership, but at the time we did not have it. So I had to send it to my previous colleague who does take care of people with adult with cerebral palsy as a surgeon. So she had all the surgery came down. So this is the story what we have every day in my clinic, that we don't care, but we care about only disease. We don't care about the human itself at all. So that has been a huge problem. So this is the, now I'm not pointing out the surgeon, I'm not pointing out our physicians ourselves, I'm pointing the system failure. We have to think about where we're gonna start. So the accessibility really begins before the clinic visit. When my patient arrives, I was looking around, how they're gonna get into this curb, going through the curb, coming to the elevator. I think it's very difficult, small. And then, as I said, we have ballet, so we invited our colleagues here to discuss these things. So start from the physical access. And then when they come to the clinic, we just discuss, do they have a Hoyer lift? Do they have an appropriate scale kind of stuff? And clinic. This is another my problem as a department chair. I have to think about the financial component of our department. I have to go with the hospital policy or strategic plan. I usually spend 1.5 hours for a new patient, but I talk to my faculty members, you have to finish your patient in 40 minutes. Impossible, actually. We have to be very rude. We have to cut in the middle of the conversation. So I have to review 30 years or 20 years of history one night before the clinic. So I can come up with my critical questions, and then I apologize to family that we will continue to explore your problems. So the problem is scheduling issues, but more so we need a longer time to assess those patients. And staff training. My patient gets very upset because we turning around to caretaker immediately, even though my patients are smart, but they are not able to talk maybe. But they turn, oh, so by the way, how Paige is doing, what's her medical history? And here we go, mom said, can you turn your head? Can you talk to her, right? We all make this a simple mistake. And then all the procedure accommodation for communication and sensory feeling, all the things we just ignore. So let's conclude, because I'm not the only one who's going to share all the information. So my conclusion, I was thinking about what I'm going to put in conclusion and for the improving the transition. So we have to build a structured transition program to support the move from the pediatric to adult. It's given. But number two, why don't we use AI? Why don't we use this technology? If we use AI-enabled tools to summarize a history, improve communication. I mean, it should be implemented yesterday. I don't need to talk about this one, right? And then we should really, why we have to ask patients to come to all different departments? Why can't we have one location, one building, where we go there, we see our patient in the same place. So I was dreaming about department store. First floor, we have a hairdresser, barbershop, Starbucks. Second floor, we have a gym. Third floor, we have a psychiatrist, psychologist. Fifth floor, pain doctors. Sixth floor, urologist. Eighth floor, Dr. Kim's office, penthouse. Right? Why we always ask patients to come? Why can't we go there to provide? So we don't need to spend the money to build these things to everywhere. Why can't we put everything in one place and we go there, right? Agree? And then we really should expand education and training. Why is that? Because we are not educated for our patients, right? I was telling my resident that PMNI is the best medicine. Why is that? We are not only dealing with the disorder, disease, we are dealing with human, comprehensive care and function and quality of life. That's why we have to be educated. But medical school, we don't have any section for teaching whole spectrum of disabilities at this time. And then not only medical school, our all faculty, our all staff, they have to be educated. Lastly, create the accessible healthcare environment through the inclusive design and equipment and transportation and clinical process. So take-home message is that adults with childhood onset disabilities deserve lifelong and accessible and coordinated care through structured transitioning program, specialized workforce training, disability-friendly healthcare environment, AI-enabled care coordination, and multidisciplinary adult disability centers. So actually more fun is coming next. So thank you very much for listening to me. And I'd like to, thank you. I'd like to invite my team, and please come to the front. So I'd like to introduce our team members who's going to be in the panel. So Mr. Ryan Bond, who is in charge for our valet parking, and Jillian Smith, who is a rehabilitation nurse, has been devoting her life for the rehabilitation and education. And Nate, I call him Nate, my son. Nate is our social worker and also therapist, and he's joining us. And Teresa Bedford, who is the best out of, I think, the whole team. She's our MA, and she has been devoting her time for our patients. And everybody is extremely happy whenever she involves care. And then she's the last one, but the most important person, Sabrina Sipes. She is our manager, actually, but also she's a physical therapist. She has been implementing a lot of great things for our patient care and then environment, and she's going to share her experience. So I'm going to start with, because the time is limited, we have a wonderful story because I spend too much time. I know who I am, so. Can you briefly introduce yourself, why you are in this kind of role? You want to start?
My name is Ryan Bond. I oversee the valet operations here at UTSW. First, I guess let me thank Ms. Long. She probably didn't realize this when she invited me for it. She was just bringing in someone who works for the valet, who's over the valet operation. What she doesn't realize, though, is my wife works for Dallas ISD, where she is a diagnostician. So on a daily basis, what she does is diagnose kids with autism, dyslexia. So when you were up there talking, it kind of came home to me a little bit. So. Sorry. I'll repeat that. But once again, my name's Ryan Bond. I oversee the valet operation. But what I was saying is, when she invited me, she just knows me from the valet operation. But what she did not realize is my wife works for Dallas ISD, and her job on a daily basis is to basically diagnose kids with autism, dyslexia. So a lot of what you were saying up front, I kind of deal with every day. Of course, the downside to that is my wife also diagnosed me all the time. So that is the negative. But also too, my mother's been in a wheelchair for about the past 5 years. So like I said, I'm very glad that you invited me for this particular panel. But like I said, my job is basically just to make sure all the cars keep moving and everybody gets into the hospital.
Thank you. How about Jillian?
Hello. Okay. Hi. So I'm Gillian Smith, and I am currently the unit-based educator on the inpatient unit at UT Southwestern at Zale. I have been a rehab nurse for close to 29 years, and what I love about it is dealing with patients in all stages of either getting a new diagnosis, taking care of patients who have had a diagnosis for a long time and helping them deal with whatever their new reality is. And with every single patient, I treat them as if it could be me, because every single one of us is one accident or illness away from being one of these patients.
Thank you.
Hi, everybody. I'm Sabrina Sipes. I am a physical therapist. I have been a therapist now for almost 20 years. So it has been a while. I think the reason why I'm here on this panel today is I do definitely have a unique perspective coming from the physical therapy rehab side of things to transitioning into leadership role over physical medicine and rehab. And having that PT mindset always in the back of my mind and leading with that, it does also impact how our patients experience their journey through our department, as well as all the caregivers that help support them. So.
My name is Teresa Bedford. I'm a National Registered Medical Assistant. I actually have been a medical assistant for 10 plus years. I really love what I do. My reason for getting into the medical field, at 15 years old, my sister actually had my nephew. He was born with Noonan syndromes. It is a very rare disorder. And I watched my nephew grow over the years, you know, learning through different things, learning disabilities and mental problems, things like that, all that comes from the Noonan syndromes. So I have a personal heart when it comes to disabled people. And I don't even like to call people disabled. My thing is we're all human. We all have different things that we have in life. We all are different in different ways. So when I first got the interview with PMR, I had no idea on what kind of population of patients that they had or anything like that. Once I walked through those doors, I really fell in love with what I do. PMR is most definitely a wonderful place. I have watched people come in from just, I would say a stroke. Come in, not able to talk, not able to feed themselves, and then you just see them just become better over time, just from what we do. Being a medical assistant, I'm the second person that gets my eyes on a patient. My main thing is to make a patient comfortable from the beginning that I get them from the lobby until they check out of that clinic. That's all.
That's amazing.
Hi, my name is Nathan McClintock. I am the social worker for the Physical Medicine and Rehabilitation Department. I work very closely in Dr. Kim's cerebral palsy clinic, so I understand a lot of the nuances and what goes into the care that is behind her patients, but also myself. I also have cerebral palsy, so I see not only from the professional side what that looks like, but also from a personal side. I grew up in and out of hospitals, surgeries, therapists, doctors, and so having that perspective as well and bringing that into my professional life is something that I value, something that I personally see as one of my missions, and then something that I can bring here to this department as a resource for our patients. And then in addition to that, I am also I'm a licensed clinical social worker, so I do provide psychotherapy for patients. And so having that perspective as well, the mental health side of dealing with the disability. Typically in disability, there are two types. There's congenital and then there's acquired. And so a lot of times when someone, especially when someone is dealing with an acquired disability, that mindset shift to get over going from being completely able-bodied to now you're not. That's a hard shift to get over, and even for those of us who were transitioning from pediatric to adult care, like Dr. Kim's talked about, having that shift from people were all around me, caring for me, I was well taken care of. And now that I'm an adult, that's changed. And how do I mentally get over that hump? How do I start to be more independent and less reliant on other people? A lot of times that factors into mental health as well. And so that's something that I that I work with a lot of our patients on too.
So Nate, you're the one who is holding microphone, so I'm going to ask one more question. So when you are in this clinic, what can you do for those patients who is in the transitioning phase? Because you do a lot of work, but what's your like a major role for those patients and families?
Yeah. So a big part of our clinic, a lot of our patients are coming to us from their pediatric providers. And so they're coming to us from their pediatric PCPs, they're coming to us from their pediatric physiatrist. And a lot of times it's either the parent that wasn't well educated on that transition of care process, or maybe even the patient wasn't well educated on that transition of care process, whichever one that looks like. And so a lot of times it comes down to the legal implications of that transition. And so a lot of our patients do rely on their caregivers for support, but then when they're in that pediatric realm, they're not being trained or taught or provided the information on, okay, now that my child is going to become an adult, what legal things do I have to put in place in order to make sure that that transition doesn't cause any issues for us moving forward? A lot of times that does not happen. And so that's a big part of my role, is making sure that our patients understand, hey, now that your child is an adult, there are things that you need to make sure that you have in place. Legal guardianship, power of attorney. There's a new form of guardianship power of attorney called supported decision making. That's another one that I'll often provide to our patients. And so that's a big piece of that puzzle, is the legal aspect. The other aspect is what does transition of care look like in terms of our healthcare, right? So moving from a pediatric PCP who's maybe more well-versed in disability, right, especially if they're coming from like a developmental pediatrician or a pediatric physiatrist, moving from that to an adult care model can be difficult. And I've experienced that myself personally, just having an adult PCP who didn't know what it looks like to care for an adult with my specific disability. And so making sure that, one, we have the legal implications in place, making sure we have the healthcare implications in place. And then I think the last one is probably just making sure that we have the social, emotional, and the home care implications in place, right? A lot of them are coming to us from pediatrics having an outdated wheelchair, or maybe their home, like I've had patients where their bed was too small for them now that they've grown, but they were never given information or resources on getting that now that they're an adult, or now that they're older, or more taller or bigger or wider, or whatever the case is. So that's a big part of my job, is making sure our patients have those resources, understand what rights they have, and just making sure, again, like Teresa said, making sure they're comfortable. A lot of this is based on comfort, making sure our patients are well taken care of, they feel good, they're comfortable. I also played wheelchair basketball in college, and one of the things I say is, look good, feel good, play good. So if you look good and you feel good, you're most likely going to play good. And I think that mindset goes with a lot of our patients as well. If they're comfortable, they're most likely going to be happier. Their mental health levels are going to be better. Their physical health is going to be better, and that starts with making sure they have those resources.
That's amazing. Thank you. So I think you are stealing her job. I don't want to say, but you make them too comfortable, so she has no business. Teresa is going to be fired. So I'd like to ask Ryan, how do you interact with your staff to deal with our patient population? So do you have any particular teaching course or any kind of education? Can you share with us?
Sure. We obviously we try to keep it simple. For you all who don't know, we probably move about 1.2 to 1.3 million cars a year here at UT Southwestern. So it is it's kind of one of those where we're definitely going through a lot of cars. But I guess one of the things when I first got hired, when I sat down and did the interview, a few things stuck out in the interview. One was the person who was interviewing me. He said, listen, remember, first and foremost, this is a hospital, which sometimes, like I say, you know, my guys, when they're just outside dealing with cars, we always have to bring them back to that point. I guess the second thing that, you know, we kind of talked about and I already mentioned is, like, we're going to do about 1.2 to 1.3 million cars, so you're going to be very busy. I guess the other thing is you know, we kind of started something a few years back when I first took over, and we just said to treat everyone like family. And I know that's easy to say, but when I was sitting down with my team and I was talking about it, I said, hey guys, just treat everybody like family. And they kind of came back and said, one of my guys says, he said, what if you don't like your family? So our joke kind of now has become, treat everybody like family unless you're Hector. So that's how we kind of keep it light, but you know. So, and also too, as far as the educational piece goes, you know, we talk to our guys about, you know, once again, we just want people to come to get comfortable. You know, the other thing, and I'll go back to the interview real quick, was the last thing Justin said to me was, you are the first and last impression of UT Southwestern for basically, you know, a million different cars. So, you know, no matter how great we are, once they walk inside the door to the hospital, if they've had a bad experience coming in, if they have a bad experience and they leave, it leaves a bad taste in their mouth. So, you know, it's like I said, it's a simple job, but you know, it is a lot of has to do with big smiles and just making people feel comfortable. But if all else fails, treat them like family, unless you're Hector.
Appreciate it. We have about 3 minutes, so each person has 1 minute.
Sorry.
I mean, you both were great, so. But now we go to Sabrina. Sabrina is the administrator. Now let's change the head to be administrator. So let's say you have a problem. I see problem in our clinic area. The door is not automatic doors, very heavy. Let's say we identified those problems. How would you like to change those things? Only 1 minute you have. Change it.
Oh my goodness. Okay. Challenge accepted. Go. Okay, so it's change. Change happens. It's really, really hard sometimes to make things happen in a big system, but it's not impossible. I think for us specifically, if there are roadblocks, barriers, whether it's a physical, having to do with space, access, it's something that we definitely get feedback first from our frontline, from our patients, to really understand where the situation or the problem is. And then we work with our departments that, whether it's, you know, with our safety team or our compliance team, get the right stakeholders involved to make sure that we are addressing that problem and tackling that door that doesn't want to open or that doesn't have the right button to open automatically, and be able to write that. Now, there's lots of some boring paperwork stuff that happens all in between, but at the end of the day, when we're looking at it, we're just trying to do what everybody else is talking about. Make sure that the environment is comfortable so that our patients can be comfortable, can receive the care that they need to receive. And when we're talking about settings, I think and providing that atmosphere of care, we're not only looking at the physical. I think it's really important that we're looking at the emotional piece of it and how our teams work together in a multidisciplinary approach to really execute the emotional comfort that has to come with it in setting up that care environment and the safety setting for this patient population.
I agree. Changing it is not easy, but thanks
Not
for
easy,
trying.
But
And
it's possible. I can be very creative with space.
Next question goes to Jillian. Jillian has been working for rehabilitation, but I'd like to challenge you that how would you like to educate other nurses in other specialty for them, because our patient goes everywhere, right? How would you like to share your experience with your nursing team?
Absolutely, and letting them know that our goal is to help empower our patients for whatever reason that they're there to figure out how they can work around or with that disability so that they can be as independent as possible. So that doesn't mean going in and doing everything for the patient. My famous words to my patients are, I'm not going home with you. We got to figure this out together. so that you're able to do X, Y, and Z. And having everybody have that mindset when they're interacting with that patient so that they are able to be as independent as they can possibly be.
Thank you. Teresa, what do you want to say? Closing remark.
Since you're going to let me just freestyle it, the only thing I'm going to say here is PMR, we do teamwork. We make sure that these patients are taken care of. We make sure that from the time they walk into that clinic until the time they leave that clinic, that everything that's needed from therapy to any refers that need to be sent out for anything, for as equipment in the home, for shower chairs, whatever's needed, we try our best to make sure that we get the job done. So I just want to say, once again, I love PMR, and UT Southwestern rocks.
Thank you so much. We have the most important video left, and now we're going to invite our patient. I don't want to say patient, my friend, a new friend from Oklahoma, actually. Paige is start to come to our adult cerebral palsy clinic from Oklahoma to just to be my friend, and I had the opportunity to invite her, and we're gonna run her video. But she's a writer, she's an actress, she's my best friend. She's a horseback rider. Well, how can I say equestrian? So hard. Horse rider, and she has a beautiful husband like me. No, she has a husband. She's married. So we're gonna share some of her story. But do you want me to run the video first? Yeah. I think her video is. I cried actually. I am evidence-based practice, right? Evidence-based presentation. This is the best one. You're gonna see. Is running or not yet?
I was born on a cold winter day. I had the umbilical cord wrapped around my neck 5 times.
And so that's when they said, we don't think she'll be able to do anything, really. Walk or talk or count to 10.
Every single day of Paige's life is a struggle, but you would never know it. She looks at her cerebral palsy as a gift from God.
Cerebral palsy is a condition that almost defies description. It is so multidimensional.
When I met you at that horse show, Paige, I just knew I had to tell your story.
She is a vessel to show other individuals what can be possible when so many times she's probably been told that it's not possible.
Why horses? You know, like those of us that show horses, what is our why that the horse brings into our life?
When Paige gets on a horse, she becomes a different lady. The smile when she's on that horse is just phenomenal.
There was one thing they did not know about me. Quitting was never an option.
Between the reins, this is my life, between the reins.
Your faith in God can take you to levels that are unimaginable.
And I like to also introduce her mother. Susie. I don't call Susie. I know, Mom. I feel young. But Susie made all the things happen with the Paige, so we want to say thank you.
Thank you. My pleasure.
And then Paige is going to share her story a little bit, right?
Yes.
You want to go?
Yeah.
Sure.
Yeah. I have a mic.
Oh, you do?
Here.
I thought I was the only.
Hope sees the road with a vision of possibility. Creativity searches for what can be done. Courage is the strength to ask, what can we do next? Those are 3 principles that I learned to live in my life. Potential often exists before anyone can ever see it. We begin to see it the minute we begin to take one step toward who we know that we are to become. I have learned this all throughout my life. At 6 years of age, my mom and I would drive through the streets of Fort Worth with the radio on, and the warm Mississippi voice of Zig Ziglar filled our car every day. Day in, day out. I would giggle at his story, and then I would pause and look and think about what he was saying that we do have right here. Zig, if you don't know who he is, Zig is one of the most influential motivational speakers and authors out in the whole world. He has touched millions and millions of people. He has passed, unfortunately. He touched people to tell them of their value. He told them what they could do, their personal growth. Zig was imprinting that message into my heart all these years, many years. One of his quotes that is my all-time favorite that I love to share is that you are born for accomplishment, engineered for success, and endowed with the seeds of greatness. I had no idea what a foundation he would leave in my life. At 9 years of age, I walked into my first horse show arena. I was a tiny little girl on this huge horse. And the announcers were go through the arena. The judges are watching every move you make. And I had monarch-sized butterflies in my stomach. But there was one question I never had to answer because I knew that I was meant to be there. I also knew that I wasn't there to be anyone else. And I was there to do the best that I can. That is what it is like we say, what can be done next for the teenage patient to transition into the adult care. It's very important. For me, I am very focused on mental health and personal growth. As they say in the video, I was born with cerebral palsy. At 18 months of age, my parents already had horses. So they bought me my own Shetland pony named Shorty. And he was sweet, but I'll tell you, he's pretty honest too. But I was so tiny, my parents would hold me on to Shorty. And I would grab fists of his mane to hang on and giggle the whole time. But we didn't know then the science that was happening, that his gait was mimicking the human gait. And that was helping teach me how to walk. I was just having fun. And that was the beginning of my life. But my mom, of course, as you can see, we're not your average. We like to do the best we can. And she got creative. She put me in ballet lessons. Mind you, I have cerebral palsy. She put me in tennis lessons. She put me in strength training. But we even did boys lessons at one time. All to strengthen any part of my body. I continued to show horses, and I've been showing for 48 years now. And it's because the horse still strengthens my core, stretches my hamstrings, and helps keep me going. Because I am determined. I won't ever quit. But it's so important to look for the potential. It may not be seen yet, but it is there. Look. I mean, dig deep to look for any possibility, for anything a patient can do. Because the doctors back in my time, cautioned my parents and said, you know, Paige, she might not ever walk or talk or have the cognitive ability to count to 10. And for the family's convenience, just put her in an institution. That is when my mother began to ask that one question: what can we do next? Creativity is so important. There is a way to get to the solution you want to get to. Imagination allows us to see what could be. We cannot let our minds become a boundary of our imagination. As one of the old sayings, the greatest nation in the world is imagination. Nowadays, I'm so proud to say that I've come full circle with Zig, and I am a certified motivational speaker with Zig Corporation and a life coach. And it's a pleasure to be working with them. I am still showing. About 15 years ago, I met the man of my dreams, my soulmate, an angel. And we've been together 15 years. I had to go a long way to find him, though. He was over in England. And yes, we did meet online, which scared my mom half to death. But he is amazing. I brought him from England to Oklahoma. He had never seen a cow in his life. And I made him into a cattle ranger. He loves ranch. Now, we have had our adventures together, many on the ranch, and also through the ADA that was started July 26th in 1990. That helped me to travel. And actually, before I met him in college, I traveled independently. I would fly from Dallas to Denver, take a shuttle to Winter Park, Colorado, and ski all day long, every day, with my favorite ski instructor. They asked me to be on the disabled ski team. But this is something very important. Possibility is important, but you have to recognize which possibilities you want to take on. And that is meant for your patient. When you are looking in your patient's eyes, look closely, dig deep to see what can be done. There is potential. Search fall in line and get creative for what is next. Because there's so much inside of every single human being. I don't care if you have a disability, a physical disability, or an invisible disability, or none. Live your dreams. But also find out the dreams of the patients and help them, empower them to live their dreams. I love what Zig says. He said, you don't have to be great to start. You just have to start to be great.
Well said. Thank you so much, Paige, for being with us to share your story. What an amazing story you have shared, and so inspirational for all of us. Dr. Kim, thank you for just all that you do to your team of fantastic individuals from the clinic, from the valet, and from the nurses, from the MAs, from the social works. Oh my goodness, all of you are amazing folks. And I appreciate everything that you do to make UT Southwestern one of the best places to take care of everybody, because everybody has potential. Thank you for being with us. We look forward to seeing you for our next event, which will be in September. Yes, August is off. September for Hispanic Heritage Celebration. Have a great day.
Of course, thank you.
I think we come.